Make sure that's actually recording. Yes. All right. Any questions from the first half? Nothing at all. All right, fantastic. Next up, I want to talk about chronotropes, inotropes, and vasopressors. So obviously chronotropes do what? Increase heart rate. Inotropes do what? Increase contractility. Vasopressors, they increase constriction of the veins, right? They get the blood pressure up, right? Veins and the arteries. Good. So as we just mentioned this, just keep in mind that drugs can fulfill multiple roles, right? So as an example, something like epinephrine fits into which of these categories? Chronotrope, inotrope, and also vasopressor, right? So you can tend to find that some drugs may just fill kind of one small sliver of that. Some of them can be wide-ranging, and we'll kind of look at the different options here. And this is good test questions to ask, because right, if I have a patient in a vignette that says, okay, they're hypotensive bradycardic, one drug might be better than if they're just bradycardic but the blood pressure is looking okay. Or if they're tachycardic and hypotensive, right? So we have different options we can try for all of those different pressors and different agents that might fulfill those roles a little bit better, as we'll see. First one I want to talk about is dopamine. Dopamine acts just like the dopamine in our body does, right? Now, keep in mind this. Why can't we give dopamine for patients with Parkinson's? Yeah, it can't really get to the blood-brain barrier through there and to actually help treat that. So again, this isn't going to really help your Parkinson's patients at all, but it works very well more peripherally, working as a systemic agent on the blood pressure, right? And so what's kind of interesting with dopamine, and actually, it's a metabolic precursor to both norepi and epi, so it makes sense why it has these vasopressor and chronotropic, inotropic activities here, but it's very dose dependent with dopamine. So when you give small doses of dopamine, say 1 to 5 mics per kilo per minute, and again, notice here's the actual how we're administering this, and when I say mics per kilo per minute, does that mean it's like an intermittent dose or it's a continuous dose? So if I'm saying per minute, it means that every minute they're getting this amount of drug, and that means basically until I say stop the medication there. So this is a continuous infusion. The majority of these are going to be continuous infusion medications. And why do we like continuous infusion medications? Well, I can titrate it, right? So again, if the pressure is too low, I can go up on the dose. If the pressure is too high, I can go down on the dose, right? You're titrating it until they don't need that support anymore. And then you can take it off, and then hopefully they can fly on their own. So you're going to find that low doses like this, dopamine, when given as a continuous infusion, 1 to 5 mics per kilo per minute, is mainly going to work against dopamine receptors. And if anything, what that's going to do is help to increase renal blood flow and help with urine output, which can be helpful, especially if you think about one of the big issues with vasopressors. When you constrict all those blood vessels, where does the body preferentially shuttle that blood to? The heart and the brain. So the kidneys take kind of a backseat to that. So lower doses here, you can find dopamine can help a little bit with that renal blood flow. And oftentimes what you can see with long-term vasopressor use or high dose, you can end up seeing acute kidney injury due to the fact that you're constricting all those vessels on the afferent arterial, I should say. I screw that up every once in a while. On the afferent, heading into the kidneys, they get so constricted that you're really decreasing your GFR. Urine output's going to go down, right? So this can actually help with that a little bit. Normally, you're not going to use these kind of doses. You're going to kind of blow right past that to get into the 5 to 10 range, where you're going to find that this works more preferentially on the beta receptors, more specifically on beta 1. So activating beta 1 does what for me? Inotropic effect and chronotropic effect, right? You're going to get both of those effects there. So I'll see heart rate, contractility are going to go up, and then subsequent to that, cardiac output's going to go up. That's good. So I had a patient who maybe was having a CHF exacerbation. Say the blood pressure is probably hypertensive because they're hypertensive at baseline, but I know the cardiac output's not good. They're not really perfusing all that well. This is where something like dopamine in this 5 to 10 range can be good because it's going to give a little bit more kick to the heart, help the LV function out a little bit, and hopefully get the output up. One thing you can see. If I go to higher doses than that, say 10 to 15 or so, or 10 and up, you're going to find you get a little bit more preferential effects on the alphas. So you're going to find that you get still the effects on the beta receptors in the heart, so cardiac output's going to go up, but then you're going to find you see more vasoconstriction, and that's where the blood pressure is going to start to rise up a little bit based on that alpha-1 activation here. So if I had a patient who was hypotensive bradycardic, this may be a good option for them. And in fact, a lot of people would, this was their baseline vasopressors, just what they used to go to all the time, right? They're starting to fall by the wayside a little bit, but you're still going to find dopamine used very frequently out there in the hospital setting. As mentioned with adverse effects, so it doesn't matter how much vasopressors you give to a patient. If the tanks are empty, you're never going to get that pressure back up. And what I mean by that is the intravascular volume needs to be full in order for those arteries to have something to squeeze on, right? So what you're going to find is that you need to make sure that before you start any vasopressors, you're going to give them what beforehand? Fluids, right? You got to get what kind of fluids? A normal saline, so more specifically isotonic fluids, or I guess less specifically isotonic fluids. Not hypo, not hypertonic. You just want to give isotonic fluids because remember what we said about where does all that volume stay? Stays right there in the veins for the most part, right? What else could I use if I did not want to use normal saline? I could use lactated ringers. Good. What else could I use? With D5W, remember that's all free water. That dextrose, once it gets metabolized or it gets shuttled into the cells, that's all free water at that point. So again, that's kind of even though D5 is isotonic, it really is just all free water, right? So again, it's a good thing a point to make there. 5% albumin, you could actually probably use as well, but that's not a crystalloid. That would be a colloid. Remember, albumin's a protein, so if you ever had someone who had low oncotic pressure, sometimes you'll use albumin in those cases there, so that would be sometimes used. But for the most part, IV crystalloids are going to be a much safer, cheaper route to go, normal saline being the most common one. And what concentration is normal saline? 0.9%, right? Half normal saline is 0.45, quarter normal saline is 0.22, 0.225, you know, to be specific, but yeah, 0.9 is normal saline there. Now again, by having overactivation of the beta receptors, right, you're overstimulating the heart, you can see dysrhythmias that can develop here, right? You can see sinus tach, obviously being a very common one. PVCs can develop here, palpitations. And then when you start to get doses up very, very high, right, so again, you kind of want to cap out your dose, and you usually don't want to go much above 20 mics per kilo per minute. You can start to see this flanking vasoconstriction, so you can develop this mesenteric ischemia, right? And normally you don't want the gut to start to get ischemic. You can see all kinds of nasty stuff happen there. Tissue starts to die off. You get infections, not good. And then, as I mentioned, you can develop ventricular arrhythmias. So the higher the dose goes, the more stimulation on the heart, more likely are to run into one of these issues here. Okay, with the alpha stimulation, getting too much arterial constriction, you're going to find cold extremities. That makes sense because, again, that's not a preferential place for blood to go. Renal hyperperfusion, chest pain in some cases. You actually develop some angina associated with this, and that's going to be more in patients with histories of myocardial ischemia, etc. But those are big things you can end up seeing with that. Other big things to note as well is with any of these vasoconstrictors, what happens if it gets outside of the vein? All those little tiny capillaries and things like that are also going to get constricted as well, and so that can cause some pretty significant tissue injury. It can cause necrosis because then you're not delivering oxygen to that tissue because it's so constricted. And so we can actually use something called phenylephrine. It's actually an alpha blocker, and we can administer that to try to get those vessels open back up, right? So that's one thing we can do for those. And that'll be pretty similar for any of these vasopressors we're talking about, whether it be epinephrine, norepi, any of them. Phenylephrine can be a good agent to use if you need to get that tissue to kind of loosen up a little bit from the blood vessel standpoint. Now, epinephrine, again, lots of different uses we have for epinephrine, right? So we have things like topical use, right? So if you have like a laceration, you want to add some lidocaine with epi, you can use it for those for topical use. Inhaled epinephrine, not used too commonly there. You don't know what you normally use inhaled epinephrine for? Probably some peds. Croup is the most common thing you'll end up seeing that used for, right? So usually you'll get inhaled epinephrine. What else do they get? That's dexamethasone, right? So that's going to help out with that the upper airway edema there. Good. And then the more common thing you're going to see is intramuscular administration, right? So when do we use this as an intramuscular medication? Anaphylaxis, right, is the most common one, right? What do most patients who have a history of anaphylaxis get to go home with? An EpiPen, right? Again, do people accidentally stab themselves with an EpiPen? It happens, right? And remember, where do you not want to give epinephrine to, say if you're using with lidocaine? Fingers, toes, penis, and nose, right? So again, you don't want to use it in those areas because you worry about that terminal blood flow being cut off, causing tissue necrosis. Well, if I stab myself in the finger with an EpiPen, that's actually another case where we can use things like warm and cold compresses to try to get the drug to absorb, but then also we can use that phenylephrine as well. That's a not super common, but it's a call we'll get to the poison centers occasionally. They say, oh, I accidentally stabbed myself. Now the finger's getting really white. It hurts. What do I do? Oftentimes I have to send them in the ER for that. Anyway, so when we're using epinephrine as a vasopressor, so instead of, say, using it intramuscularly as a single dose for anaphylaxis, this is going to be a continuous infusion being used as a vasopressor, right? In ACLS, we're talking about it uses an intermittent dose given every 3 to 5 minutes in the patient's coding, right? So you're giving a milligram every 3 to 5 minutes for those patients. Here, this is going to be a continuous infusion run on a pump, and you're going to find this has pretty balanced effects between the alpha and the beta, okay? This doesn't have those same kind of dose dependent effects like dopamine did, but you're going to find that it's going to have very good effects to cause arterial constriction, so blood pressure is going to go up, heart rate's going to go up, cardiac output's going to go up, right? This is a good balance between that. So if someone's hypotensive bradycardic, this is also another good one to use. What I see clinically is more often than not, this is going to be kind of a backup. So say if someone started on dopamine and it really wasn't doing the job, sometimes they'll add on an additional pressor, and epinephrine's a good kind of backup agent to that. Or if someone was having kind of persistent, hypotensive shock secondary to anaphylaxis, this is also a good agent you can use for those patients as well. You start off with that. And again, as I mentioned, very similar side effects to dopamine. Again, you're going to see the risk for arrhythmias, you're going to see the renal hypoperfusion, etc. So just be aware, the higher the doses you're driving up on these, the more likely you are to see those side effects. Okay. Next, we have dobutamine. So this, again, don't get this confused with dopamine. Big difference between these, because this one is actually just going to be a strict beta-1 agonist. Okay. So is this going to be good for someone with hypotension? Not really, right? Because again, you're only going to see the beta-1 effects, the cardiac output effects with this one. So this is an inotrope only. Hopefully it shouldn't have too much effects on the heart rate, but you're going to find it may have a little bit of bleed over there. But the big thing is try to improve that cardiac output. We use this pretty frequently for patients with decompensated CHF. So if they were hypertensive kind of at baseline, but we know they're not perfusing well, the cardiac output's not really good, this is where dobutamine can come into play. It's activating those beta-1 receptors to try to get that LV function up a little bit, to try to get them perfusing a little better, right? So as we see that pretty commonly. Sometimes we'll actually use this as well for cardiac stress testing. So if you ever see that, we'll sometimes use this as an agent to try to stimulate the heart for patients who may not be able to, say, do an exercise and do a stress test, to try to see what kind of ischemic kind of issues they develop there, right? So it's something you may see. Again, because of the fact that it's activating just the beta-1 receptors, it's going to be arrhythmogenic, which means it can cause PVCs, ventricular arrhythmias, etc. It's just a known side effect that's seen with the drug there. Why would it cause angina? Increasing what of the heart? Oxygen demand. So if they had issues of, say arteriosclerosis, and we're not perfusing those vessels very well, you can see that oxygen demand is going to go up and they outstrip the supply, and then develop angina there, right? So it's for patients with a history of angina. Usually you're going to see that gets exacerbated there. Another one we have is called Isoproterenol. This is Isuprel. This is more frequently, this got used a lot frequently back in the day, but it got replaced by dobutamine. We still see this used occasionally in terms of provocative testing, which means that stress testing I was talking about. Sometimes you'll see it there, sometimes in pediatrics. But again, it's another beta-1 agonist, so the same effects as dobutamine apply to this one, right? So again, just being able to determine which ones are beta agonists, it's really dobutamine and isoproterenol. Next we have Milrinone. I think we talked about this possibly before. We were talking about CHF. Anyone remember what this does? This is actually another phosphodiesterase inhibitor. If you remember back, what other phosphodiesterase inhibitors have we covered? So Denafil, all of your erectile dysfunction medications, the oral ones at least, they work on PDE5. If you remember, which PDE causes the eye effects? 6. What about the musculoskeletal effects? 11. Good. This is actually PDE3 that this is working on. So when you think about cardiovascular, not in the lungs though, right? Because again, remember that sildenafil still works on for pulmonary hypertension. That's still PDE5 you're talking about. PDE3 though is going to be good for more on in terms of cardiac output, in terms of the kind of systemic vasculature. So anyway, so this is basically trying to inhibit the breakdown of cyclic AMP by inhibiting phosphodiesterase 3. Okay. So what you're going to find is this helps to increase cardiac output. So cyclic AMP is normally stimulatory on the heart, so you're going to see increase in chronotropy and inotropy. But you're also going to find it's going to have negative effects on the vascular smooth muscle. So what you end up seeing, if anything, is an increase in cardiac output, but usually a decrease in blood pressure. Now, who might that be good for? Well, that CHF patient I was talking about, right? They have poor LV function, but they're hypertensive. This is actually a decent drug you can use for them. It'll help to increase cardiac output, blood pressure comes down a little bit, and hopefully that can balance out a little bit. But again, you have to worry about things like arrhythmia that can develop that, right? And again, mostly you're going to be seeing these acute decompensated CHF patients here. We don't use these chronically. This is really going to be more for like the acute decompensation, like in the ER, in the ICU, because we do see that this risk for ventricular arrhythmias is fairly high, and we do see increased mortality. But in the short term, it's relatively safe to use for those patients. And obviously, the biggest side effect you're going to see is hypotension, mainly due to the effects on that vasculature. Next one is norepinephrine. Levophed is the brand name. Anyone know what this was commonly, not lovingly referred to as? It's called leave 'em dead. It's kind of an old nomenclature. So this used to be the thing where if like a patient was not responding to dopamine, they weren't responding to epinephrine, and they were like, well, the patient's about to die anyway, let's get the leave 'em dead out here. That's basically where the name came from. Nowadays, we're starting to use this kind of first line for a lot of patients, right? So if you have someone who's hypotensive that needs a good vasopressor, we like norepinephrine quite a bit. Almost exclusively in terms of toxicology, this is what we like to recommend for patients who may have like a TCA overdose or aspirin-induced hypotension, any kind of thing like that. And this is good because it, again, mimics the effects of natural, normally occurring norepinephrine. What you find, though, it has a little bit more balanced effect on hitting the alpha receptors than it is on the beta receptors. So if the issue is they're getting hypotensive because maybe they have, say, too much amlodipine on board, right? And they're hypotensive because of that. The heart's working fine, right? If anything, they're probably tachycardic because the heart's trying to compensate for the hypotension. This is a good agent there, right? So by increasing the squeeze on the vessels, you're going to get the blood pressure up, and that's actually going to help the cardiac output to go back down. Does that make sense? So you have a patient who's hypotensive and tachycardic. They're probably tachycardic because of the hypotension. Norepinephrine is a good drug for that because it's going to help to increase the alpha squeeze on the vessels there. It's going to get the blood pressure back up, and then the heart can kind of relax a little bit and say, okay, SVR is back up, I can take my cardiac output back down. And everything's kind of back into balance there. So this is a good frequent one we're going to be using, and most of the time it is getting used as a first-line agent in a lot of places now. Another one you may see used quite sparingly. Now, we talked about phenylephrine before. Where did we mention it previously? Yeah, you can use it for priapism. It can help it if it's if actual manual drainage is not working. Then you can use phenylephrine to try to vasoconstrict there. Where else do we use it? As a decongestant, right? What did I say about it being used as a decongestant? Terrible, right? It's not a very good drug as a decongestant. However, when applied intravenously, it is an excellent drug. It's a very good alpha constrictor. Actually, just pure alpha constriction, right? Norepinephrine still had some beta effects, right? Still had some effects on the heart, but this has pure only alpha-1 constriction here. So obviously we mentioned topical preparations, oral preparations previously, but this is the parenteral one we're talking about. This one is not used as a first-line agent. This is always going to be used as a backup. So if the patient's on, say, Norepi and Dopamine, but they still can't get that pressure up, and they want to go ahead and add a third agent, this is oftentimes used as a kind of a third-string sort of agent here. And again, this doesn't have any effects on cardiac output. Only is going to get the blood pressure back up by causing that vasoconstriction there. So a good example of this would be, we had one case where anyone familiar with the drug minoxidil? We know what that's used for? For hair growth, right? What is the brand name typically? Rogaine, right? How's Rogaine cause hair growth? It's just a vasodilator. It actually causes increased hair flow, blood flow to the follicles, increased hair growth. In fact, minoxidil used to be, was originally studied, was to be used as an antihypertensive. Found it was pretty crummy antihypertensive, but they had all this hirsutism was developing, and so let's try using it for hair growth instead. So I actually had a patient, if you don't know anything about minoxidil, it actually has a lot of alcohol in the product in order to get it into solution. And so we had a patient who ended up, he was a chronic alcoholic, lost access to any alcohol, and so he says, I need to find something, otherwise I'm going to go into what? To withdrawal and potentially delirium tremens, potentially seizures. They know it's potentially deadly, right? So to stave that off, he decided to go to the local Walgreens. He's looking for stuff, and he looked at the minoxidil and he said, oh, there's actually a decent, it's like 35% alcohol or something. So he said, I'm going to drink all of this. So then we find him passed out. He's passed out because why? Well, because he's super hypotensive and he's not perfusing the brain anymore because of the direct vasodilating effects of minoxidil. This is actually a really good case where phenylephrine was able to be used. The patient was extremely tachycardic, hypotensive, and we got to use a pure alpha constrictor to kind of counteract the effects of minoxidil and got the pressure back up. Just an example of how you can try to kind of custom tailor the medications used based on the clinical situation. That's just one example. Another one you might see used occasionally is called Vasopressin, Pitressin. Now again, does anyone know another brand name that sounds pretty similar to Pitressin? You see Pitocin? Pitocin is a brand name for oxytocin, right? So you want to make sure you don't get those two mixed up there. So vasopressin is another name for that as what? ADH, otherwise known as arginine vasopressin, AVP. If you ever see that, that's also another name for it. So vasopressin, it works as ADH. So what is that going to do for us? Holds on to more water, increase thirst. What does it do to the blood vessels? Vasoconstrictor, right? So again, this is another good add-on agent. This is something where if the patient is remaining hypotensive, say you start them off on norepinephrine, they're on dopamine, but you can't really get the pressure under control. Oftentimes what you can find, it's especially in patients with very severe like inflammatory conditions, say they come in with sepsis, right? So they're having kind of body-wide inflammation due to this bacterial infection. The capillaries get very leaky, right? So there's kind of third spacing fluids out of the vessels, and you can give them isotonic fluids all day long, but it just keeps leaking out into the third space and isn't really that effective. So what you can do potentially is to give them Pitressin, or give them Vasopressin to try to help decrease that leakiness, right? Basically, it's going to hold on to those fluids better, and that can help to get those pressures back up. It makes your isotonic fluids a little bit more effective in those cases there. This is why I use it as a backup. Also, you can use it in diabetes insipidus, which makes sense because, again, what's the main cause of diabetes insipidus? Usually either a lack of ADH or you have a resistance to it in the kidneys, right? What's a good drug that causes diabetes insipidus? Yeah, lithium's the one you think about most commonly. So it's good for that. You can also use it potentially for GI tract hemorrhages. This actually can help to constrict the esophageal varices. It can help to deal with bleeding. So you may see it used there occasionally. And for the most part, it's been replaced with that DDAVP, right? Remember that nasal spray we talked about for those patients there. However, for in the ICU use and the ED use, when you're adding on an additional pressor, this is another good one you can use as a continuous IV. So again, if they are septic and they're still hypotensive and they are not responding to fluids and pressors, add on ADH, add on vasopressin, you should get some pretty good effects from that. So that's why we like that. They used to recommend it in ACLS, but they took that out of the recommendations. Now it just says epi, epi, epi all the way, right? And of course, what do you think are some side effects of giving ADH? You see things like hyponatremia, right? You worry about the water intoxication, it's a possibility there. But for the most part, not really a big issue for these patients. Okay? Most of the time they're so sick, they're intubated, sedated anyway, so it's not really a big concern. So how do we pick an agent? Again, consider what the patient condition is. You know, if they have poor cardiac output but the systemic vascular resistance is okay, we'll go with something that's a more positive chronotrope, inotrope, right? So Isoproterenol, Dobutamine, Milrinone, those are all fine. You know, cardiac output and SVR are both diminished. Okay, let's use something activating alpha and beta, right? So use something like high-dose dopamine, norepi, epi are all going to be fine agents there. What about if the SVR is diminished, right? So say I had that minoxidil patient, cardiac output's okay. Well, norepi is always a good first stop, and for most patients, norepi is going to be a good first stop for them. And then phenylephrine may be a decent backup agent, okay? And again, it's not uncommon to see patients on 2, 3, 4 pressors potentially when they're really are the sickest of the sick, okay? And of course, this is one of those situations where, like, if you ever see someone who's on 3 or 4 pressors, look at their other medications as well to see if something is causing hypotension. Because a lot of times those patients are intubated, and I see them on propofol and say, you should probably get that propofol off of there, and that'll help out the pressure, and usually get them off a pressor or two. As I mentioned, septic patients, oftentimes they're going to need that vasopressin. That's another thing to consider adding on. So just real briefly, just going to kind of brush over a few other things, just to mention here, good things to cover in terms of emergency medicine. Hyperkalemia. Again, what's a normal potassium? 3.5 to 5 is a typical normal potassium here. Now, what do you think is the most common reason why a potassium level will come back high? You may have covered this like in your Clin Lab course. Hemolysis is a very common thing. So oftentimes off of a lab it'll come back and it'll say like the potassium's like 7, and the patient's like totally fine. You said, okay, that's probably hemolysis. Usually the lab will report that out. They'll say, hey, hemolysis happened here, but sometimes it may not, right? So again, you always take the clinical picture into account. But let's assume the patient actually is hyperkalemic. You know, what are some common causes for that? Acidosis is a good one. What else? Say it again? Yeah, rhabdo is another good one. Yeah, absolutely. Renal failure. Maybe their intake. Maybe they decided that they're going to gorge themselves on 1,000 bananas. It's not very common, right? Yeah, medications, right? So again, if you saw like say they had renal impairment, they took an ACE inhibitor. It's going to cause potassium to go up, right? So these are all things to consider, right? Usually renal failure is probably one of the more common ones you're going to run into as a reason why they're holding on to all that potassium. Anyone know which antiarrhythmic drug used for CHF can increase your potassium levels? It stops the sodium potassium pump. Digoxin. Digoxin is the one that can actually increase your potassium as well, based off it blocking that sodium potassium ATPase pump from bringing potassium back into the cell. Anyway, so we talked about the common causes for that. You know, NSAIDs are another thing to consider with a patient with chronic renal failure, you know, because you can decrease that perfusion there to the kidneys, things like that. And obviously the big things we're worried about are the ventricular arrhythmias that can develop from this, right? VFib, asystole can definitely develop here. And again, there's some neuromuscular findings as well that can happen, that can kind of precede this. But again, the ways we're going to treat this are, one, we'd like to get rid of the potassium if we can, but sometimes you don't really have the time to do that, or you may not have the facilities ready to do that right away. And so what we can do is some temporizing measures to try to keep, either to treat the arrhythmia or to try to help protect the heart until you can get these more definitive therapies on board, okay? And if I mentioned this before, but it's the CA big K drop is the mnemonic I like to use to remember the different agents here. First off is going to be calcium. I mentioned calcium likes to stabilize the myocardium, right? So again, it helps to prevent an arrhythmia from occurring. This is typically one of the first things you're going to be giving these patients here. Okay. Next, we have albuterol. Now, why does albuterol help with hyperkalemia? Albuterol does what? Beta 2 agonist, right? So by activating beta 2 receptors, that actually causes an inward flux of potassium. So that's another thing that will help to shuttle, displace that potassium. Now, do you think it's going to be a very good definitive sort of therapy? No, right? It's kind of a stopgap. Most patients do not require albuterol, especially if you have IV access already, or if you can get IV access. But if you were, say, out in the field, all you had was a nebulizer with albuterol and no other access, yeah, you could do it, right? Sometimes we'll use it if we're still needing time to kind of get other stuff set up. So that's one thing that's kind of optional. Next, we have bicarb. What does that do for us? It's going to draw into the cells by alkalizing the patient, right? By increasing the pH, one way to do it. And then insulin. Got to give insulin by itself? Not typically. Typically, you're going to give it with glucose, right? Because again, you have to get the two together to help stave off the hypoglycemia. But again, that will help to shuttle. And you're bringing that glucose, you're bringing other stuff as well, like amino acids, bringing potassium as well. So that can help to drive the potassium down. What type of insulin do you think we use? Usually, regular insulin is the only one, right? You wouldn't want to use a long-acting. You could use potentially like a Humalog or something like that, ultra rapid acting, but probably 10 times out of 10 I've seen a regular insulin being used here. Because again, relatively short acting, we have a pretty long history with it. We know exactly how it works and how long it's going to work for, etc. So we'll give that along usually with like a 0.5 gram per kilo of dextrose, and then that's going to help to kind of get that potassium shuttled in. And again, this is a temporizing procedure. If you let it wear off, potassium is going to come right back out, and you're back to where you were to begin with. Now, another drug we haven't covered too frequently is called K-exalate, or sodium polystyrene sulfonate is another name for that one. And basically, it's either an oral med you give, or it's a rectal medication you can administer as well as an enema. And basically what it does is it will exchange sodium ions for potassium ions. And so by doing that, it will help to, basically it's like trying to pull potassium out of the body into the gut. And by doing that, it's going to help get the potassium down. Now, it's not a very fast process. It's not, right? So again, it's one of those things where it can help a little bit, but it's not going to be like the really, really definitive thing. But it's the only thing we talked about so far that actually gets potassium out of the body. So it is helpful from that standpoint. So again, it can be useful in the short term. However, the biggest thing you can do, oh yes sir? Could you use that for hyponatremia? I haven't seen it used for hyponatremia, because then again, if you were using it for hyponatremia, then you run the risk of getting hypokalemic, right? So again, I have not seen that used for that purpose specifically. Yeah, as always, you can treat hyponatremia anyway. So the final definitive therapy is going to be dialysis, right? So again, if you need to actually pull that potassium out of them, filter the patient's blood for them, help get that potassium normalized, put it right back into them, and then you're good to go. Okay. So again, that's one of the indications. If you remember, what was that mnemonic I used for indications for dialysis? So it's A-E-I-O-U. So the A, acidosis. E, electrolytes. I, intoxications, right? So if I had like a toxic alcohol, like a radiator fluid, or if I had aspirin overdose or something like that, so intoxications, you can pull it off there. O is fluid overload, so you can actually pull off extra fluid off of the patient there, so you can actually set how much fluid you're putting back into the patient when you dialyze them, so you can do that. And then the U, uremia. Yeah, so again, those are your more chronic kidney disease patients, right? So those are the 5 things I like to remember as far as common indications for dialysis. Okay. But those are the big things to remember there. Again, K-exalate and dialysis are only things that are actually pull potassium out of the body. Everything else is just shuttling it into the cell for a short period of time. Calcium, though, again, just really stabilizing the myocardium, not really doing anything to potassium levels directly. Again, we talked about all that. Again, keep in mind that some of these are going to be relatively short acting, especially like calcium, maybe only 30 to 60 minutes. It will give you time to get things like dialysis set up. Because again, it may be difficult depending on where you're working at. It may be hard to get dialysis even started. If you're at a big like educational facility where they have like nephrology residents on hand, they can come in, do the dialysis catheter, and get it started immediately. Fantastic. If you're in the middle of nowhere, you may have to be arguing with your nephrologist to actually come in and do it if it's the middle of a Sunday night. They may say, it'll wait till morning. Just give them some potassium, or give them some insulin and dextrose and bicarb, they'll be fine. Maybe, maybe not, right? So again, it depends on how you make the argument. Again, beta receptors, albuterol is the more common one. There's another drug called terbutaline used occasionally, but albuterol is a more common thing. Again, trying to pull that into the cells. They're usually given via continuous nebulization until you can get more definitive IV access for the patient there. Okay. Again, insulin and glucose here, this is really helping to activate that sodium potassium pumps. That's why you end up seeing increased activity to pull that potassium into the cells. You have to give regular insulin here, and you have to make sure you're giving dextrose along with it. You have to get the two together. Okay. In some cases, you may have to give a dextrose infusion afterwards, like D10 or D10NS or something like that, in order to make sure to keep the sugars in their normal range. And then to get rid of it, as I mentioned, diuretics we could potentially use. You could use something like a Lasix, but oftentimes that's not going to be effective enough, and you get the patient dehydrated anyway, so it's not really all that recommended. So again, we'll use that sodium polystyrene sulfonate or that exchange resin. We'll switch sodium for potassium within the GI tract, either orally or rectally, and that will help pull it off. But pretty slow process there. And then dialysis is going to be the best thing. Within 1 to 2 hours, you should have a 1 to 2 milliequivalent per liter drop of their potassium. And we know what a normal course of dialysis runs. How long? Usually about 4 hours, yeah. And so that should be able to get the patient back down to a normal level relatively quickly, which is great. And then real briefly, anaphylaxis. You guys know this. We've covered it before back in the pulmonary section. What are my fast-acting meds for anaphylaxis? Epi, right? Epi is going to be the first thing. If they are having airway closure, if they're having severe hypotension, anything like that, Epi is going to be the first thing you're going to be administering to those patients, right? What other drugs are we using? Steroids, like what? Dexamethasone is a good one. What's solumedrol? There's a generic for that. It's methylprednisolone. Yeah, so dexamethasone, methylprednisolone, those are more common things. Hydrocortisone could be potentially used IV. Probably solumedrol is a more common one I see used for anaphylaxis. So I can use that. So again, is that fast-acting, long-acting? It's going to be more long-acting, right? So again, it's going to help me kind of down the road several hours from now in order to make sure they don't have a kind of recurrence of the inflammation and the anaphylaxis comes back. So those are going to be good. You want to get it on board, but again, in the grand pantheon of things, if I have patients who might need to be intubated for this anaphylaxis, get the epi first, right? The steroids can wait a few minutes. It's not a. And I've had nurses before. They're like, we got to get the steroids, and I'm like, chill out. Like, let's get the other stuff first. Let's worry about that. I don't say chill out to them, but I say internally, I go. And then verbally I say, okay, we'll get that started. But in the meantime, let's try to get the diphenhydramine. Let's try to get the other, right. Again, it's all how you portray yourself. And so anyway, so the H1 blockers we're going to use here, diphenhydramine, far and away most common one. And again, most patients who have like an anaphylactic reaction to anaphylaxis are probably going to get antihistamine, may or may not get steroids, may or may not get epinephrine. Epinephrine is always going to be more the questionable one, depending on how severe the reaction they're having. If they're hypotensive, if they're starting to have that airway closure or anything like that, epi is absolutely given. But in some cases, more mild cases, we're just having some pruritus, some flushing, Benadryl may be enough for those patients, right? So most of the time, though, they're going to get this. Now, do I need to give an H2 blocker? Not necessarily. Again, we know that extra histamine is going to cause some stomach activity there. It's going to cause some extra acid production, but it's not required to give it something like a Zantac or nitidine. But you can. It can maybe help out with that, especially if they're like getting nauseous and having any kind of GI discomfort along with that. As I mentioned, corticosteroids, for more mild reactions, you can certainly use oral doses of steroids, right? Dexamethasone, prednisone, anything like that. Now, what's the difference between prednisone and prednisolone? Anyone know? Prednisolone is a liquid form. Prednisone actually gets turned into prednisolone in the body, but prednisone is the tablet form. That's the big difference. So usually for kids, they'll get prednisolone. For adults, probably give them prednisone, right? Methylpred, any of those are going to be fine there. Again, they all take time to work, several hours, in fact. Obviously, the more severe the reaction, the more likely we are to use an IV product for those patients there, right? Epinephrine, as we mentioned here, again, I'm not going to ask you specifically about doses. Again, you can use IV potentially, but it's very, very uncommon you would do that. Mainly if you had someone who is having severe cardiogenic shock due to anaphylaxis. More often than not, it'll be an intramuscular dose we're administering for those patients. And again, oftentimes you want to ask the question, especially with a history of anaphylaxis from the patient, ask had they gotten anything already, right? Usually, patients with anaphylaxis will have already given themselves a dose of epi, and so you don't want to necessarily have an extra dose if they don't need it, okay? So any questions on emergency medicine stuff from a farm standpoint? Now, let me check the board real quick to see if there's any questions. Before you all run out of here, I know everyone's excited to leave. Let's see. So these ones we've already answered. This one is in incredibly tiny text. Oh my gosh, I can't even read that. Here you go. Does giving dopamine at higher doses still have the lower dose effects? Like if you give 10 mics per kilo per minute, still increasing urine output. So those effects specifically, the really low dose effects will probably get overshadowed by the vasoconstrictive effects. But certainly if I were to say go up to say 10 and above, I'll still get the cardiac effects you saw from 5 to 10. Okay, so the renal effects probably not so much. Still can decrease kidney perfusion, can still cause acute kidney injury at those higher doses. I think that was it. All right, thanks. I'll see you guys next time. All right, so any questions from the last time we met? So long ago. Oh, is it? Oh, yeah, that's right. Oh, man, I gotta use the hand mic. Okay. Is this working now? Yeah, it's definitely working. Those of you on the second floor should feel very proud. You got an exclusive wood joke that the first floor didn't get, so keep it a secret. We don't want those losing their value, right? Anyway, so we covered RSI last time, so we talked about some sedative meds, some paralytics. We talked about our pre-meds, right? What pre-meds do we use for RSI? Lidocaine, which is good for increased intracranial pressure, and what else? Atropine, which is good for patients are bradycardic. Who else might be good for? Either very young children who are going to be getting succinylcholine, they're more likely to get bradycardia, or if they're getting repeated doses of succinylcholine, you may want to consider before the second or third dose, go ahead and giving the atropine there. Okay, so getting into ACLS, which is, what is that? Advanced cardiac life support. You'll actually find it's pretty basic when you get down to it, right? You're going to find that the medications we're using here, it's very much, it's all algorithm based. There should not be a whole lot of free thinking going on in terms of just doing the actual process of coding a patient. So we'll talk about the meds we're going to be using here, what situations they're going to be good for, which situations they're not going to be good for, and then we'll have a few kind of miscellaneous topics we'll talk about to finish this up. So anyway, so some of the medications we're going to be covering here, some of these we've already covered. Some of them are antiarrhythmics. We'll cover them again briefly here. It's good to remember what are the common side effects, what are the mechanisms. Good to know. We'll cover that briefly here. But then we'll get into some other ones, things like calcium. We'll talk about dextrose, which we kind of covered back in endo a little bit. Magnesium, when we're going to use that, naloxone, etc. So a lot of these are going to be rehashing old drugs we talked about, but in this new situation of actually like when you have a patient whose heart is not beating, what are you going to do for him to get it beating again? So first things first, has anyone ever dealt with the Bristojet before, or one of these type of medications here in this type of syringe? One of the biggest things I wish someone had taught me before I went to my first code, and they're like, here, drop this medication for this patient who's actively dying, is I couldn't even figure out how to get the medication together, put it together to actually give it to the nurse to actually give to the patients. Quite embarrassing, but you figure it out pretty quick. And so a lot of times if you go to check out a normal code card or something like that, or a code tray, that will have medications that are built like this. And essentially what you have to do is you'll have the barrel here. Let me get the laser pointer. You have the barrel here, and here, which is kind of nice, it's either a lure lock in. Does anyone know what I mean when I say lure lock? It's a type of IV connection, so it actually will screw into a catheter that's placed intravenously, so it's a standard connection you're going to see there for most IVs. So it has a lure lock there on the end of that, or what you could actually do is just take this whole thing off, and there's actually a needle there, so if you needed to directly put that into a patient, you could potentially. Then you also will have the glass actual vial of the medication there, and basically what you're going to do is you have to flip off the yellow tops here and here, so basically just take your two thumbs and just pop them right off, and then you screw it in. Seems very simple. However, if in the heat of the moment, and they're like, hey, this patient's dead, we're trying to bring him back, can you hook this up? And you're like, ugh. Just do it once or twice and you got to kind of have the hang of it. I remember actually my first code I went to, we were on a shortage of epinephrine, and so we had to use a concentrated form, and we had to make sure we were doing the dilutions correct before we gave it to the patient, because if you give too much epinephrine, anyone know what can happen? The heart explodes or causes a stroke or something like that. So it was like, okay, so let me get this really concentrated stuff, make sure I dilute it correctly, make sure I do the math in my head right, and then actually hand it over. So that was a little harrowing, but fortunately you don't have to do that too frequently. But anyway, so again, these are actually how you end up putting them together. Dextrose comes like this, epinephrine, atropine, bicarb, all the common stuff you're going to talk about today will come in syringes like these that are pretty typical. Now, What's nice about with most adult coats is that you can just push the whole thing, right? So they're designed for that way. One dose is basically going to be one of these syringes here. However, it gets more complicated, especially in pediatrics, when you have to get much more customized with the dose you're administering, right? Because this could be way too much if you're dealing with, say, a 3-kilo infant, right? We'll talk about some ways to deal with that in a little bit. And again, just remember, you just have to pop off the yellow tops and then screw them together, and it's pretty easy from there, right? Also, these are glass, which is unfortunate, because if you drop one on accident, you're going to get medication everywhere. And if it's dextrose, guess what? You got a big sticky mess all of a sudden. Not fun. You just more instructions on how to put those together. And again, once it's screwed in, basically there's a tiny needle on the end of the barrel here that will actually screw into the rubber seal that's on the end of the medication, and then it's good to go at that point. Okay, so starting off, let's talk about medications we're going to use for bradycardia. How do we define bradycardia typically? Heart rate less than 60. Now, is that actually a problem for some people? If you're a very well-conditioned individual, you may have a resting heart rate in the 50s, no problem, right? But again, this is considering the situation of someone who is bradycardic, which is not their normal, right? So the first medication we'll talk about here, and this is kind of a good one to start with because in terms of ACLS, this is pretty much your go-to medication for 9 times out of 10 of the situations you'll run into, is going to be epinephrine, right? What does epinephrine do for us? Cause vasoconstriction, good, so that'll help out with what? Blood pressure, get blood pressure up, good. What else does it do? Bronchodilation, yep, so it can help out with that. So if you think about it being used for like an anaphylactic reaction or something, it can help out with bronchodilation, good. What else? Chronotropic effect, right? So again, it's going to be bumping up your cardiac output. It's going to get heart rate up. It's going to also get the contractility up. So it's a chronotrope. And what do you call it when you're getting the contractility higher? It's a positive inotrope, right? So again, the actual electrochemical force, all the ions that are flowing to actually increase the actual squeeze is going to be going up there as well. And remember, it's going to be acting pretty equally on both alpha and beta receptors there, right? So when you're talking about the vasoconstriction, what receptor is causing that? I know I've taught this to you before. Probably every lecture this comes up, at least 8 times. Alpha-1 receptors, right? It's activate alpha-1 receptors that cause vasoconstriction. Epi is going to do that. How about for the heart? How do we get the chronotropic and inotropic effects? Beta-1, right? Beta. You have one heart, but you have 2 lungs, right? So for the bronchodilation, it's beta-2, right? So some people remember that. So remember what kind of effects, and that's going to be important when we get into the individual pressors in a little bit, because we're going to talk about things that are beta-1 agonists specifically, alpha-1 agonists, so it's important to remember that kind of the balance there between the actions of the different receptors. So again, it's going to be good for helping to increase blood pressure, heart rate, and actually helps with coronary perfusion as well. So if your patient's having an MI, this can help out with that, get more blood flow going there to the heart. And our indications are typically if you have a patient with symptomatic bradycardia, right? So again, if you have a heart rate of 54 and you're a triathlete, that's no problem, right? Because you're not going to have signs of bradycardia. However, what could be some evidence of bradycardia in someone else who might be symptomatic? Fatigue, lethargy, pallor, they're not going to be really perfusing all that well, things like that you're looking for. And again, if the blood pressure is low because the heart rate is so low, that again is something you use to consider them symptomatic there, right? So we'll use it for that, and then we'll also use it for cardiac arrest. So whether they're in VFib, VTAC, asystole, PEA, it does not matter. They're probably going to be getting epinephrine every 3 to 5 minutes. Okay, we'll talk about dosing and all that a little bit later on, but in general, you can use this for anything. We'll talk about some medications that are good for VFib or VTAC, but not really good for the other ones, and then vice versa. But epinephrine is going to be good for any of these. Okay. So I'm not going to ask you specific dosing on the test, but I just want to kind of give this to you for reference here. But again, note the how frequently we're going to be dosing this medication. So if you had a patient who is bradycardic that was symptomatic, and you had someone who's in active cardiac arrest, you're going to be dosing it every 3 to 5 minutes. Remember what I said about the time, how that time feels during a code? It dilates out, right? So again, it's one of those things where you really want to make sure you're marking down the time on when patients got stuff, including epinephrine, because this is something that should be going kind of like clockwork. You're going to be, someone's going to ask you, hey, where's the next dose of epinephrine? But hold on a second, it's only been 2 minutes, it's only been a minute, whatever the case may be. You need to wait every 3 to 5 or so. Now, note there's a couple different concentrations that are out there. This is actually an important point because you don't want to get the concentrations screwed up here. There's one that is a 1 milligram in 10 ml solution. I have a slide on it to cover this in a second. And I have one that's a 1 milligram per 1 ml solution. Okay, so one's much more concentrated, 10 times more concentrated than the other. When you're using IV doses of epinephrine, you want to use the lesser concentrated form. Why do you think that is? So it's going to be going straight into the system, right? Versus say something like a sub-Q or intramuscular dose. But the other thing is that you can be much more fine in terms of controlling your dose, right? So again, imagine you drew the whole thing up. It's much easier to have fine control over 10 mLs of volume than it is when you're trying to push in 1 ml of volume, right? So because of that, we like to use the less concentrated form. And then for something like an IM dose, like if you're administering it for say anaphylaxis, that way you're using the more concentrated form, the 1 milligram and 1 ml. I'll talk about the old way we used to talk about the concentrations in a minute here. But anyway, so if you ever see a 1 to 10,000 solution, that basically is that less concentrated form. It's 1 milligram and 10 mLs, and that's the one that comes in those Bristojet, so I was just talking about a second ago. As a max, you would never give more than 1 milligram, and that's only if the patient's like actively coding. If it's a bradycardia, you may be giving a smaller dose, say something like 0.5 milligrams potentially. Because again, if they're just bradycardic, you need less of positive chronotropic effect versus if their heart is just not beating at all, right? That makes sense? Anyway, also of note here, you can actually give, this is one of the few medications you can actually give via the endotracheal tube. So why do you think you'd ever have to give a medication via the endotracheal tube? If you didn't have access to the veins, right? Now, nowadays, what could we use instead if you didn't have IV access? Use an IO, right? So at a point where IOs maybe were not as commonplace, or we didn't have those nice little power drills we can use, we ended up using more endotracheal tube dosing. I've honestly never seen it. You may do this like perhaps if you were, say, like on a mission trip somewhere, you're out in the middle of nowhere, and you needed to provide epinephrine. This maybe it could happen, I don't know. But anyway, there's a nice mnemonic we use to remember which medications can be used endotracheally, and it's lean. Epinephrine is going to be one of those. It used to be naval. We used to use Valium, but we don't do that anymore. But it's lean now. I'll talk about the other ones as we get to them. Anyway, what do you notice about the dosing for epinephrine via the endotracheal tube versus via IV route? It would be higher, lower? Probably higher because you're actually not getting as good a bioavailability as opposed to putting it straight to the veins there. So you'll notice here it's a lot higher dose. If I use a max of 1 milligram IV, I can use it to a max of 2.5 milligrams. And that should give you essentially an equivalent dose there. So again, that's something you'll probably do very commonly, but just for reference's sake. So, and again, actually a lot of the products that are out there have taken out this type of nomenclature here where they did a 1 to 1,000 versus 1 to 10,000 because it just got people confused. They would mix up the two all the time. I'll tell you a really good example of this. I remember when I was doing my fellowship and I was in the middle of the emergency department, and we had probably 2 active code reds that were going on at the same time, so 2 cases of cardiac arrest going on at the same time, and so staff is pretty tight, as far as how many people you have available to code these patients here. But I remember they wanted to hang an epi drip. Okay, so an epinephrine drip for this patient here, and so that's one of those things that we would have to mix at the bedside. So one of the nurses was handling that, and so it was a new nurse who was working. She was tagged up with another more senior nurse, and so in our code cards, basically we had the syringes that we had of the 1 to, this one was actually the 1 to 10,000 solution, so it's less concentrated. Normally we would push that into a bag of D5 and then just hang that and you're good to go. We also have a very concentrated vial of 30 mLs of epinephrine. So 30 whole milligrams. And so the less seasoned nurse was like, oh, do I put this whole thing into the bag for the epi drip? And the other nurse, not knowing what she meant, actually she assumed what she meant, she said, oh yeah, go ahead and push the whole thing. So she ended up drawing the whole 30 milligrams instead of the 1 milligram into the bag and almost hung it on the patient. Fortunately, someone caught it right beforehand and said, hold on a second, we don't want to explode this guy's heart. It's already not beating to begin with. And so we ended up halting that. But again, be very careful, and that's one of the big points I'll make later on, is that you always want to make sure you have very good closed loop communication. When I say that, what does that mean? Nothing should be left out in the air. Everything should be very specific. So if I say, do you want this whole thing in this bag? You say, no, I want 1 milligram of epinephrine and a 250 bag of D5, right? That's very specific, that we can't get it screwed up. You'll notice this when you go into your SIMs as well. It's like, okay, I'm giving fentanyl. How much? What concentrate? These are things you have to consider, right? So okay, I'm giving 25 micrograms of fentanyl to this patient via IV, or whatever the case may be. So you want to be very specific with that. And that's how you can avoid a lot of those errors. Because if you think about it, if you think about the time from you deciding I want to give a medication to a patient to when the patient actually gets that medication, when do you think it would be quickest? What kind of clinical setting? Usually in one of these code settings, right? Because again, you say, I want to give epinephrine, and someone's going to push epinephrine within seconds, right? So again, that time to catch those errors is very short, and that's why you want to make sure you're being very specific. Versus, if you write an order on a post-op patient, and I look at it in the pharmacy 5 minutes later, and I look at it's wrong, it's like, okay, I'll get to that in a few minutes. The med's not scheduled to start for 2 hours. You got time to catch those mistakes there. Versus in a code, you got really not very much time. Anyway, so nowadays they got rid of that kind of confusing nomenclature there, and you'll just see the actual concentration, whether it's 1 milligram per ml or 1 milligrams per 10 mLs, whatever the case may be. Anywho, as I mentioned, the endotracheal tube is only used as a route of administration very sparingly if you didn't have any IV access whatsoever. But again, you need to use 2 to 2.5 times the normal IV dose. It's actually much higher than that with epinephrine. You saw we're using the more concentrated form there. And so the ones we use here, the lean mnemonic is going to be for lidocaine. Which again, why would we use lidocaine in a code situation? We don't want the patient to feel this. Numb them up. No. You're going to use it for cardiac dysrhythmias, right? So you're going to be using it for ventricular arrhythmias less commonly nowadays, but that's what you'd use that for. Epinephrine, atropine, we'll talk about in a second here, and then naloxone as well. What is naloxone? Narcan, what is it used for? Versus opioids as well. Yeah, it's only action there, right? Again, should rarely be done, but I just kind of mentioned it here in case you ever get a question on it or preceptor tries to pimp you on it. It's like, hey, what meds can I give intratracheally? You'd be like, oh yeah, lean. I remember that. Probably won't remember it, but once he says it, he'd be like, oh yeah, I totally remember. Dr. Wood told me about that many years ago, right? Or last year, whatever the case may be. Atropine's the next drug we're going to be talking about here. This is also used for bradycardia. Now, if you remember, what does atropine do? We talked about this yesterday. It will speed up the heart rate. How does it do that? I heard it. Blocking acetylcholine, fantastic. But which receptors? Muscarinic receptors, absolutely right. So it's blocking. It's an antimuscarinic drug. It blocks the effects of acetylcholine at the muscarinic receptors, right? So by taking off that vagal effect on the heart rate, that vagus tone, you're decreasing that. You're going to be finding that you'll get that increased chronotropy, increased inotropy on the heart, right? Again, this is good, especially like for certain types of poisonings. If you have way too much acetylcholine effect on those muscarinic receptors, right? Remember we talked about neostigmine, how it causes the dumbbells. Remember what the killer bees were? Bronchuria, bronchospasm, and bradycardia, right? So again, this is how we treat that, right? So we're going to give atropine as an antimuscarinic. So if a patient's bradycardic for whatever reason, you can administer this and it'll get the heart rate back up, right? What other effects would you expect to see? It's the anti-dumbbells, right? So remember, it's the mad as a hatter, red as a bee, hot as a match. All those things you can see there. When dry as a bone, you're also going to see they'll dry out secretion. So again, that's why it was nice for things like in RSI, if you're using ketamine, it had a lot of excess secretion, to give atropine and help dry them out a little bit. But in terms of ACLS, you're really only going to use it for symptomatic bradycardia. We used to actually alternate it with epinephrine during cardiac arrest, but that is no longer a recommendation, right? So nowadays we're just going to be using it for symptomatic bradycardia, right? So if a patient's vaguely down for whatever reason, or AV block or anything like that, those are the patients going to get atropine most often. More frequently than not, you're going to see this being used with RSI if it's used at all. I don't see it too often for codes unless they're just specifically bradycardia, kind of prior to them coding. And so typically what you would find if you had a truly bradycardic patient, you probably start with atropine first, and if that's irresponsive to that, then you go ahead and switch over to the epinephrine most commonly there, right? Because with the epinephrine you can run into lots of other side effects. So what kind of effects would you expect to see from epinephrine? Probably hypertension is probably one of the more concerning things, right? So again, if they're bradycardic, yeah, you can get the heart rate back up, but if they're hypertensive to begin with, that can be an issue potentially, right? Anyway, so this is another one you can use via the endotracheal tube. Dosing here, you'll know the maximum is usually 0.5 milligrams, even though the syringe may come in a 1 milligram size. That was the old code dosing, and so we don't really use that much anymore, but 0.5 milligrams is usually pretty good to help get the heart rate back up and hopefully help with that perfusion. Now let's go over to the tachycardias. First off, we're going to talk about adenosine. You guys remember we talked about adenosine before? What is it used for? SVT, right? So supraventricular tachycardias, right? So could I use this for VFib, VTAC? Nope, it doesn't do anything, right? All this does is help to decrease the conduction from the atria to the ventricles, right? And again, remember how we talked about it when you give it, what happens? Basically stops the heart rate just for a brief second there. So if you get a chance to look at those continuous EKGs you're going to do on the patient there, it's super cool to watch, right? It's a little scary, very cool to watch though, especially when it comes right back on sinus rhythm. It's awesome from that standpoint, right? So again, what are some other things you could do to treat SVT? You can try to have them vagal down, right? So again, try to increase acetylcholine effect on those muscarinic receptors, right? So again, instead of using something like atropine, you try to get the patient's own acetylcholine to work a little harder, get that heart rate back down. If that doesn't work, then oftentimes we'll break out the adenosine for those patients there. What was the other thing we talked about in terms of administration that was of particular note? Very fast half-life, or a very short half-life, we should say, right? It gets broken down very easily, very quickly. So what does that mean as far as administration goes? Got to give it quick, right? So that's why you want to always have those the stopcock with the 3 ends on it, and that way you have a saline flush on one end, you have the drug on the other end, and then the other end's onto the patient, right? And so that way you can go ahead and administer the drug very quickly, and then the flush behind it, and that way you're hopefully getting, because most of the time this is in a peripheral vein, you want to get that drug to the heart as quickly as possible. Very frequently people get the first dose and they don't push it fast enough, and then you end up saying, well, it wasn't effective, it didn't do anything. So they give the bigger dose, and by the time they give the bigger dose, that's enough of it to actually make it to the heart and actually break the SVT. So if you push it fast enough the first time, that's always good. Just keep in mind, if you're ever dealing with those 3-way stopcocks, wherever the handle on it is facing, that is off. I only mention that because very frequently people try to hook this up and they'll push the drug and they can't get the saline going. And it's because the thing is in the wrong position, right? So you have to face it away from wherever you're trying to go to. And again, this is like simple stuff that like you're probably going to screw up if you ever do it your first time. You'll feel totally dumb. You'll be like, oh yeah, I remember that. But it's okay. It's a good learning experience for you. Anyway, but you can see here that typically we'll start off with kind of an initial max dose of 6 milligrams, and if that doesn't work, then you double up the dose, right? So you give a bigger one to see if it is going to go ahead and work and break that SVT there. You can use other things like potentially we could use something like a beta blocker if it was still ineffective with this, like esmolol, something we can use potentially. Diltiazem or verapamil. Remember what kind of drugs those were? Those are calcium channel blockers. They dihydropyridine or non-dihydropyridine? Non-DHPs, right? So you can use verapamil, diltiazem. That can also be used if it's unresponsive to adenosine for whatever reason. So this is a picture of that stopcock there. So again, if this was hooked up to the patient, you had your drug here and your saline flush here. If this is faced this way, and even tells you off, but again, who can read those tiny little letters, right? So you don't want to face in this way. You actually want to face in the opposite direction, so that way the fluid can flow in all 3 directions here, right? So you're going to push the drug in this way, push the flush in, doesn't matter which one's to which, and this goes to the patient essentially, right? And so again, because of that very short half-life there, that's why you have to push it with the saline flush behind it. Up next is amiodarone. What's amiodarone good for? Kind of everything, right? It's a very wide application of use for amiodarone because it can work for both atrial arrhythmias and for ventricular arrhythmias as well, right? So again, if you had, say, someone who is in, a flood or something like that with very rapid conduction of the ventricles, sometimes amiodarone can be used for that. But more often than not, especially in like ACLS type talks, so you're talking about VFib and VTAC are the more common things you're using amio for, right? Now again, if a patient's actively coding and they are asystole, or I'm sorry, VFib, VTAC, what's kind of the first thing you're going to do for those patients? What's often, Yeah, you're going to put the AED on so you can do what? So you can shock them, right? So again, typically you're going to try shocking the patients first, and we'll show you the algorithms here in a few minutes. If the shocking does not work, then that's when we bust out the amiodarone. So this is kind of a secondary thing if the patient's like actively coding. Now, if the patient was, say, more stable, say it was like, say, an AFib or something like that with that rapid conduction, and they're still like kind of with it and conscious, then you might go with the amiodarone first. It just really depends on the patient's situation. But in terms of ACLs, you'll learn that typically you want to shock them first. If that is not they're not working well, then you go ahead and switch over to something like the amiodarone for them, right? And typically you'll start them off with a big bolus dose up front, and then you follow it up by a drip. Now, why do you got to do a bolus and then follow by a drip? What's the point of the bolus? It's a loading dose, right? Loading doses do what for us? Get the steady state fast, right? So again, it's going to get us up to our steady state right where we want to be, because again, amiodarone has a very long half-life, and if you just were to dose it normally, how long would it take to get to half-life or to steady state? 4 to 5 half-lives, and you ain't got days and weeks to wait for amiodarone, right? I know it sounds like I'm having got to like parrot stuff back to me, but again, that's why we repeat things over and over again. So that way it kind of comes to your mind very quickly when you get asked it on rotations or something, right? The little connections are facilitating them. So again, it's very good. If a patient was unresponsive to adenosine and maybe they weren't a good candidate for verapamil, diltiazem, or something like that, then amiodarone could also be potentially used for an SVT. If you remember, how does it work? It's a class 3 antiarrhythmic, and class 3s have what mechanism? Not calcium channel, it's actually class 4. Potassium blockade, right? So block outward efflux of potassium. And what does that do to the refractory period? it increases it, prolongs it, right? Because if you remember, the thing that initially sodium will cause the potential to go up in the cell, but that resetting, right, when you get that the repolarization occurring there is due to potassium efflux. And so by blocking that, you can prolong that refractory period and kind of interrupt that reentrant rhythm that's causing the arrhythmia, essentially. So that's why we like that from that purpose there. It has a lot of other actions as well, but the main thing is that potassium channel blockade. How would that manifest on an EKG, do you think? Potassium channel blockade. It's prolonging the repolarization. QT prolongation, right? Because if you think about it, the QRS is the ventricular depolarization, the T wave is ventricular repolarization, right? So again, if I'm elongating that, making that longer for the refractory period longer, it's going to take longer to get to that T wave. And so by doing that, you see QT prolongation. So if you ever have any drug that blocks potassium efflux, you're going to find that's going to cause QT prolongation and put you at risk for SODs, right? For SODs to points, right? Twisting of the points. And how would you treat that? Magnesium, right? Good. Yep. So any side effects to worry about with amiodarone? You remember? Yeah, so again, this is more chronic dosing as you worry about either hyper or hypothyroidism. So that is certainly an effect you can see. Long-term dosing, you see like blue-green or blue-gray kind of discoloration of the skin. These are not things we're too concerned about right up front when we're using this in terms of ACLS, but you do want to be careful of seeing things like bradycardia, hypotension, potentially torsades if the QT was already prolonged beforehand. So again, just you're going to be monitoring them anyway from a cardiovascular standpoint. Just watch out for that stuff, okay? And again, sometimes you have to re-bolus patients with amiodarone if the first dose is not working there. So sometimes we'll give them up to 3 doses for a max of 15 per kilo. And if that's not working, then we kind of have to go with something else. We've got to figure out what else is in our toolbox there. Now, typically, if your patient is still perfusing, they're still with it, you don't want to push this medication because you're more likely to see that hypotension develop there. However, if they're coding, then you can just go ahead and push it, right? Because the patient's dead anyway, so go ahead and push it. Try to get that rhythm stopped so that way the heart rate will get back into a normal rhythm there. Okay. And then again, as I said, the perfusing you can give it over a longer period of time, say 20 to 60 minutes, and then you follow up with a drip afterwards if it's effective, right? If it didn't work in the first place, there's no point in using the drip. Next we have lidocaine. This used to be used more commonly in terms of ACLS, but now it's not recommended too often. You'll still find it in the code cards, mainly for RSI, or potentially if you are maybe unresponsive to amio, maybe you can try a lidocaine potentially, but we know how this works. It works by blocking sodium channels, a 1B antiarrhythmic, and it's good for ventricular arrhythmias, right? This would not be a good agent used for like AFib, A-flutter, stuff like that. Not going to be a good agent, but for ventricular arrhythmias, this would work. As I mentioned, amidarone's kind of taking lidocaine's lunch from an antiarrhythmic standpoint. So you're going to find that you use much more frequently. This may be a backup. Okay, just be careful if you have patients with renal or hepatic clearance issues, because again, this is another one you put them on a continuous drip. They're going to hold on to that drug for longer, and so you can end up seeing that toxicity there. And what do we say local anesthetic toxicity looks like? They get the paresthesias, they get the tingling sensations, the metallic taste. What can that lead to? Seizures, yeah, that's a big thing. Is seizures, and then obviously it can cause arrhythmias as well, right? So any of these antiarrhythmics obviously cause arrhythmia. Again, you can see we start with a loading dose and then start with an infusion afterwards in order to keep us at our steady state. But you'd have to monitor that and decrease it for patients that have things like hepatic impairment or CHF. Why would you think CHF would need a lower dose? Typically, they have a lot of backup of fluid, right? So they actually have impaired hepatic delivery of blood and delivery of that drug, so less of it is making it to the liver. So obviously, the half-life is going to be elongated there, right? So that's one thing to consider with the CHF patients. If the drug never makes it to the liver, can't get metabolized, right? Again, this is another one you could use as an intratracheal administration, but again, we probably won't have to do this in your career most likely. Next, we have magnesium. Have you ever seen one of these arrhythmias? That's scary. You don't want to see that, but you do know how to treat it. To hit them with magnesium, yeah, absolutely. All right, so hit them with the magnesium. That'll break the torsades hopefully, and then you'll see here usually we'll give 2 grams, usually a typical adult dose, to try to break that. Seen it used a few common times for that. More often than not, you're probably going to use this for a lot of like L&D patients with like preeclampsia or something, but or eclampsia as the case may be. But in terms of torsades, this is why we keep magnesium in the code cards there. One thing to note, especially if you're giving this, because if you work in emergency medicine, you'll probably end up giving more magnesium for. Anyone know what condition we might use it for? Yep, yeah, I'd actually probably be more likely than not be using it for like status asthmaticus or severe asthma exacerbations. Why do you think we like to use it for asthma? Yeah, it causes smooth muscle relaxation. It's kind of like the body's natural calcium channel blocker. And so that goes to a reason, or stands a reason why we'd have hypotension as a side effect here as well, right? So again, watch the blood pressure. You may need to give them some extra fluids. What kind of fluids would you want to give them? Normazoline, right? Just give them some normal saline, tank them back up. That's going to be good. Because again, it's vasodilation is occurring there, so if you can fill that space up with volume, with fluid, that's going to be able to help get the pressure back up, right? So typically, if you are giving it during a code type situation where the patient's not perfusing at all, you just go ahead and just push it. Versus if it's for something like asthma or a less dire situation, you can give it over a longer period of time because you do want to watch out for that flushing and the hypotension that will develop with that. And in fact, for instance, in our ER at Nemours, we actually have it paired up to where anytime you order magnesium for asthma, it automatically comes with a typical fluid bolus for those patients. And for a pediatric patient, what's a good fluid bolus? 20 mLs per kilo, right? So again, we'll hit them with 50 per kilo of magnesium, and then you'll have that 20 mLs per kilo normal saline bolus to go along with it to make sure they don't get hypotensive. Up next, we have sodium bicarb. What is this going to be used for? For acidosis, that's going to be one of the more common things we're going to use it for sure. So again, because it's our base basically, right? So it's going to be able to help get the pH back up. And what's a normal pH we're shooting for? Say, go for 7, right in the middle. 7.35, 7.45 is considered natural, normal pH for most healthy individuals, right? If you're 7, you're pretty acidotic, right? So this is when you might actually need sodium bicarb. Just be aware it comes in 2 different concentrations. There is the adult one that comes in a 1 milliequivalent per kilo, or I'm sorry, 1 milliequivalent per ml concentration, and then there's an infant one that is less concentrated. It's about a half milliequivalent per ml that we would give there. So that's if you see 2 different sizes, one's for infants and one's for older patients and adults. Other things we can use it for include hyperkalemia. We'll talk about that in a little bit later. Anyone know what it would do for hyperkalemia? Yeah, it shifts it back into the cells. You typically find as patients get more acidotic, it will shuttle potassium out of the cells. And so you see that very frequently with like DKA patients especially. They get very acidotic, and you'll find that their potassium actually looks kind of normal for them, even though they've been peeing out a ton of potassium. By giving the bicarb, you'll shuttle that back into the cell and help to normalize that. Now, does that actually get rid of that extra potassium if that is overall what the issue is? No, but it's a good stopgap, right? It can hopefully help to either treat or prevent an arrhythmia from developing there. We also use it for certain poisonings as well. Anyone know what poisonings we might use it for? You probably don't, but I'll ask anyway. Aspirin's a big one, right? Actually, we use this for aspirin toxicity. That one's kind of interesting. I don't know if I cover it specifically in my lecture, but one of the things we do is that it can help out with increasing the elimination of aspirin. If you remember, aspirin gets eliminated in the kidneys, and aspirin is a weak acid or a base? It's a weak acid, right? It's acetyl salicylic acid, ASA. So because it's a weak acid, by putting it into a more basic solution, what does that do to the ionization of the drug? Increases ionization, right? Because remember, like dissolves like. So when you have a patient who is acidotic due to aspirin intoxication, that actually decreases ionization. It's actually going to increase its ability to get to the brain and cause seizures. Not good. By giving bicarb, we can actually increase the positive charge. You have a higher proportion of the drug that's ionized, and that prevents it from being reabsorbed in the kidneys, and you just pee it right out. So that's actually one thing we'll use bicarb for pretty frequently. That's not going to be on the test unless I cover it in the tox lecture. But again, just an example of some different uses for these medications. Anyway, so looking at this, we're going to use typically a good dose for bicarb for most patients is 1 milliequivalent per kilo IV. Hit them with that, and then you'll be rechecking your ABG, your arterial blood gas, and seeing what their pH is afterwards. Again, you can see some transient hypocalcemia due to the change in pH there, so that can cause tetany in some cases. But for the most part, you're not going to find too many issues with giving this bicarb. But acidosis, hyperkalemia are probably the 2 most common reasons why you're going to be given bicarb. Probably poisonings as kind of a distant third. Calcium, what can we use calcium for? What is it? So calcium is good for a couple of things. So one, the easy one is what? Hypocalcemia. Yeah, so if you're lacking calcium, you give more calcium, right? Another thing we can use it for is hyperkalemia. We'll talk about why that is a little bit later, but basically it stabilizes the myocardium and it helps to prevent arrhythmia, so that's a common thing you'll see it used for. And then massive transfusion. Anyone know why we'd use it for massive transfusions? Same reason why we get calcium for dialysis patients. you use the something, the thing. This is what rotation's like, just so you know. You're just like, they'll pimp you on a question, you're just like, it's the thing with the thing, I know it in the tip of my tongue.
If I have 4 choices, I can get it?
Yeah, exactly. Can you give me 4 choices? I have at least a 25% shot. No, you don't have that, right? Basically, it's used because we use that citrate anticoagulant, right? Because remember, calcium is really important for kicking off the clotting cascade by binding up calcium. So if I'm giving you a massive transfusion, say you come in as a trauma patient, you're losing a lot of blood, I need to give you a bunch of blood back. I don't want that blood to clot and wherever I'm storing it at. So they use that citrate anticoagulant to try to bind up calcium, prevent clotting. When I put it into the patient, then they can develop hypocalcemia because that citrate is also binding up their calcium as well. So sometimes we'll use it for that. And again, those are usually built into the protocols because you know that calcium is going to get used up, so you have to replace it. One big thing to note here, and you'll find this in most code cards, is that they'll have 2 versions of calcium. They'll have calcium gluconate and calcium chloride. Now, this is important because if you screw up which one you're using, or if you're not specific about which one you're using there, you're not going to get the right dose of calcium you're betting for. Okay, so just so you know, 1 gram of calcium chloride is equivalent to, gives the same amount of elemental calcium as 3 grams of calcium gluconate. Why do you think that difference is there? Well, gluconate is a lot bigger than a chloride, right, in terms of some molecular size. So because of that, that's the equivalency, right? You get the same amount of elemental calcium between those two different formulations there. The really confusing thing, though, and I don't know if I have a picture of it on the next slide or not. Actually, I'm not using the recording feature, so I can go back and forth if I want. If you look at this, they're both calcium, right? So it says calcium. They're both 10%. They both are 10 mLs, and both contain basically 1 gram of their respective salts. So as you imagine, that could be very easy to screw up if you're not looking carefully to see which one you're actually pulling there. You can either give 3 times the dose you're intending to give, or 1/3 of the dose you're intending to give. Obviously, that can cause some problems, right? Other things to look at is that typically for calcium chloride, 1 gram is going to be your max dose you're given at any one time. And again, that makes sense that 3 grams would be the max dose of gluconate based on the conversion there I gave you just a second ago. Big issues with calcium chloride, though, it is very, very harsh on the veins. It causes a lot of thrombophlebitis. It can cause tissue necrosis if this extravasates. So because of that, we like to give calcium gluconate if we have more stable patients, someone we're not having to push that calcium super hard on. So again, most of the times it's safer to give calcium gluconate, especially if you don't have central access, if you only have a peripheral vein. If you have to, if the patient's in a code type situation, if they have hyperkalemia, you're coding a patient, the K comes back and it's 8. You can go ahead and give the calcium chloride IV push, and you gotta do what you gotta do, right? But just in general, that's why we like to use the gluconate. It's a little bit easier on the veins than the calcium chloride will be. Very similar. Next we have naloxone. We mentioned we use this for what? Opioid overdoses, right? So again, what are some examples of opioids we might use this for? Heroin, good. Percocet. Percocet contains oxycodone, good. Oxycodone, Oxycontin, well, codeine, hydromorphone, what else? Fentanyl, methadone, buprenorphine, right? Be familiar with all these different medications here that can be amenable to naloxone because if you find a patient, especially like EMS, will more often run into this, but if you found a patient who is just unconscious on the floor, say you just walked in here one day and you found someone on the floor unconscious, there are several things you need to check for, kind of the easy things to rule out first, right? So, and we used to have what we call the coma cocktail we would administer to patients. And basically, so of course, first off, you assess their breathing and circulation, right? So assuming they're that, but they're just unconscious, right? A couple of things you can rule out really quick first. What do you think those are? One's glucose, right? So again, I can check an AccuCheck pretty quickly, and if they are hypoglycemic, what do? Give them the sugar, right? So I can give them some dextrose, right? That's an easy thing to give. If they are hypoxic, what can I do? Give them oxygen, good. If they are overdose on opioids, what can I do? Give them Narcan, right? So again, we call this the coma cocktail. We used to use, like an alcoholic patient, thiamine was included there. We used to use a drug called physostigmine, which we don't really use too frequently anymore. But those are common things you would use because those are the common things that cause altered mental status, depressed mental status in patients. So again, and are there any drawbacks to giving naloxone to a patient? You can put them into withdrawal, right? That's the only risk to it. So if I found a small kid who got into grandma's medications and give them Narcan, is there any problem with that? Yeah, because they're probably opioid naive. They don't have to worry about that so much. However, if it's someone who is chronically taking opioids and then maybe they overdose themselves either intentionally or unintentionally, then you got to start to worry about withdrawal. However, the options are a patient being dead, not breathing, or alive and cranky, because I just reversed the heroin they spent all their money on. Probably going to go with the alive and cranky. Again, they're going to wish they were dead. They're going to feel pretty miserable. However, that's kind of the risk versus the benefits there. Again, can you die from an opioid withdrawal? Can't remember. What could you die from as far as withdrawal goes? Benzos. What else? Alcohol, right? So remember we talked about what's the reversal agent for benzodiazepines? Flamazole or Ramazicon. Again, we use that pretty sparingly, especially in the ER, because again, if we had someone who's on, say, Xanax chronically and we reverse that, they can go into seizures, right? Because again, their brain is developed to having that extra GABA effect around from the benzos. However, the opioids, we know they're going to go into withdrawal. It's okay. We don't have to worry about that too much. So if you had someone who, even if you were not sure if they'd overdosed on an opioid or not, you can just give it, right? Because there's really no downsides to giving besides if it is an opioid and they're chronically on, then that withdrawal. And again, oftentimes, if you know specifically like it's an opioid overdose, you can try giving smaller doses to see what they kind of respond to. As long as you're oxygenating them and you're breathing for them, that's no problem there. But typical doses, say 2 to 4 milligrams, is pretty common we administer here. As far as adverse reactions go, again, that's really the only big thing to worry about is the withdrawal effects you can see with that. Okay. The nice thing you can do is just if you can give them just enough to have them start to wake up the brainstem to start to breathe a little bit, they start to yawn. That's a perfect level to keep them at, right? Because I don't need them to be awake, I just need them to be breathing, right? Next we have dextrose. There's several concentrations you can run into. There's D10, D25, D50. Why would I use one versus the other, do you think? Well, similar to calcium, you're going to find that dextrose is going to be pretty harsh on the veins, especially the higher the concentrations we're using. So typically what you'll see is that D50 is going to be more used in adult patients who are like severely hypoglycemic. D25 is more in like children, and then infants will probably get the D10, right? So to go along with that, how do you think the volume changes when I switch between the different concentrations? Which one would have the highest volume for the same equivalent dose? Lowest concentration, right? So the D10 I have to give much more volume for that patient rather than the D50. So for instance, if my typical dose is say 0.5 grams per kilo that I'm administering to a patient, so say I have someone who's 50 kilos, I'm going to give them 25 grams of dextrose, you're going to find that can be 1 to 2 mLs per kilo. Actually, in this case, it'd be 1 ml per kilo for that patient there versus if it was D25, it's 2 to 4, or if it's 10% dextrose, it's 5 to 10 mLs per kilo. So because of that, you want to make sure you're keeping your concentrations right. And when you say give the patient dextrose, you got to be specific on which concentration, how much you actually want to give in order to make sure that patient gets the right kind. Okay. Again, it's very irritating to the veins, so that's why the smaller the kid you got, probably the less concentrated forms you want to go with, if possible, right? Obviously, if I have an infant who's severely hypoglycemic and they're having seizures, you can use the D25. It's one of those things where you kind of have to take the situation into account. Okay, so looking at the actual algorithm here on how we're going to be managing these patients here. So let's say we start off with a patient who is in cardiac arrest. And you'll do this during the summertime, so have a lot of time to practice with this, but just kind of start to wet your whistle a little bit from that standpoint. Obviously, the first thing you're going to do for a patient who's in cardiac arrest, you go get the AED, call 911, right? You guys do your BLS, you always have to tell them to go do that. That's actually important, right? Because again, if everyone assumes someone else is doing something, nothing happens, right? So you start CPR for the patient, right? So I'm not going to belabor those points. You're going to give oxygen if you can, and you're attaching the defibrillator, right? What are our shockable rhythms? VFib, VTAC, right? So again, you'll check them out, see if it's a shockable rhythm or not, you'll shock them. Notice here, if we're going down this pathway here, you're going to be continuing to give CPR. Notice that once you're giving, kind of getting into the rhythm of things, so to speak, you're shocking them. This is where we're going to introduce epinephrine, right? So epi is going to be given here basically kind of in between rounds of CPR, given every 3 to 5 minutes. Usually CPR goes in rounds of 2 minutes or so between rhythm checks there, but every 3 to 5 minutes you're giving the epinephrine, okay? Again, you're checking, is it a shockable rhythm? If yes, then you try to shock them again. If they've failed 2 or 3 shocks, at that point, that's when you consider busting out the amiodarone, right? That's going to be your kind of go-to antiarrhythmic for VFib, VTAC in these patients here, okay? You administer that as a loading dose, see if they respond to it. If not, sometimes you give 2 or 3 additional doses. If they don't respond, then you have to go with something else, right? Maybe try lidocaine, maybe try anything else, right? On the flip side of this, though, if they're going down to asystole PEA, it gets to be very easy, right? This used to be more complicated because they would switch between using Epi and Atropine, sometimes use Vasopressin. Nowadays, you just give them Epi every 3 to 5 minutes. So it's very, very simple from a medication standpoint. And obviously, you want to treat any kind of reversible things that are also going along with it. So why is the patient coding is a big question, right? Do you know the mnemonic they use to determine why a patient's coding? The H's and T's, right? There's 7 H's and 7 T's. You can see here the different things that can cause this, the reversible causes. You can fix that, right? So if the issue is the patient's acidotic, then what do I give them? Give them sodium bicarbonate, right? If the patient is hyperkalemic, what can I give them? See a big K drop. We'll talk about that in a few minutes here, but I'm glad someone remembered that. Again, so look for the reversible cause. If you can fix that stuff, and that's probably going to help you get the patient back to normal circulation there, right? If it's thrombosis, you got to lyse it somehow, right? So sometimes TPA might be easier if you need to get into the cath lab or whatever the case may be. You want to reverse those causes if possible. But from our standpoint, from medications, it's really easy, right? Just give them Epi and just keep coding until you call it, essentially, right? If they have tachycardia with a pulse, right? So again, this is not a patient who's actively in cardiac arrest, but they still have a pulse, but they have maybe like an SVT or something like that going on. Again, try to identify what kind of arrhythmia is occurring here. Is it wide complex, narrow complex, etc. You know, if you determine it's SVT, then obviously our go-to is adenosine, right? If adenosine wasn't working, what might you use? Maybe like a calcium channel blocker, or you could use Amiodarone, right? So again, you have several options kind of going along with this. And again, a lot of times you're also going to be consulting your cardiology colleagues. They're going to be able to help you out with this, and especially sometimes you have like an electrophysiologist who can actually look very specifically at the EKG and be, oh yeah, you need to do this, X, Y, and Z. And then otherwise, if not, then you need to consider using something like an amiodarone or something like that. It's going to be recommended for those patients. Obviously, electricity gets involved as well, especially if the patient does not have pulses or they're not perfusing well, they're unstable. You may need to use electricity. But for this case here, you can start off with medications because the patient's a little bit better off. And for bradycardia, what are we going to use? Atropine first. And if that's ineffective, what can we use? Epi, right? So again, this is another pretty simple one. Start off with atropine. If that's not being effective there, switch over. And again, what are the side effects of atropine you're looking for? Yeah, the anticholinergic side effects, right? So you're going to expect them to be dried out. You're going to see decreased bowel sounds. You're going to see urinary retention. You're typically going to see wet in the pupils. Pretty mydriatic, right? So again, this is one of the things you're expected. If you see that, it doesn't mean you can't give any more atropine, right? So again, you're basing it off the heart rate, not necessarily just because you see the pupils dilate out. Yes, sir.
For SVT, you said that after adenosine, if that doesn't work, you can use amiodarone. However, I thought that amiodarone you can only give it for the treatment of contractions for SVT.
So amiodarone is pretty wide-ranging in terms of its indications there. So you could use it for an SVT potentially, right? It may not be the next thing you jump to, at least what I have seen, and at least in a lot of pediatric cases of SVT, we tried adenosine first. If that was ineffective, we tried using like a diltiazem or verapamil or something. And then actually with one patient who got really sick, they ended up going on ECMO. Actually started ECMO in the ER, which is a very uncommon thing we did at the time. And we actually went through adenosine, that didn't work. We tried to break them with diltiazem or verapamil, that didn't work. I believe we tried Esmol, that didn't work. We even tried, then we tried amio, again, nothing, right? So I actually had to put the patient on ECMO in order to, kind of let the heart settle a little bit, kind of get reset, and I think the patient actually did pretty well on that. They came off ECMO and did fine. But yeah, that's typically the normal course of things. And again, if you're dealing with pediatrics, and again, if you ever want to see some very anxious people, go to an adult ER and give them a pediatric code. They will be, the sphincter tone is going to be through the roof, right? So you're going to see very, very anxious people here. And so the thing you can do is try to prepare, right? So again, preparation is always going to be the key to this stuff. If you can do simulations, if you can get some practice with it, that's really going to help out. If you know where things are, right? Just even finding out where the supplies are can help to relieve a lot of anxiety, right? So again, if I show up at a random spot to a code, I need to know where the syringes are, I need to know where the needles are, I need to know where the drugs are. Everyone's going to have their own role and you need to know where the stuff is, right? That's a big source of anxiety. We also have code sheets can help us out with this, and I'll show you an example in a second. But basically, with pediatrics, the big thing is what is the weight of the child, right? So again, getting an accurate weight can be difficult. Again, if you ask me right now, put a gun to my head, say, what are the weights of your two children? I give you a pretty good estimate, but I'm probably going to be off by at least a little bit, right? Like Phoebe, we just took to the ER for croup, so I know where she weighs, but Lily, I have no idea, right? Depends how much mac and cheese she ate that day. And, it could be several different things. But sometimes it's been a while since a kid got weighed, and the parents, they're freaked out too, right? If they have a kid who's coding, so they may not know the weight off the top of their head, right? So getting an accurate weight can be very difficult. Sometimes you got to estimate. I'll show you a different way we can also look at the weight as well, the ways we can estimate it. Again, we will have code sheets that kind of give you the common doses and volumes you're going to need to administer for those children based on the weight there. So whether 10 kilos, 25 kilos, whatever it is, we can have volumes already listed there. And in general, if you have a pediatric patient who's in cardiac arrest, if you're kind of in between weights, just round up, give them a little extra, if anything, because it's better than giving them not enough drug. Okay. Here's an example of what one of our code sheets would look like. This is just an example of what we use at Nemours. If you go to somewhere else, it might look a little different. Here you have the patient weight. You have the doses of electricity we would administer for cardioversion and things like that. You can see all the different medications here that we've talked about, right? Talking about the actual volume you're actually going to administer here, because that's actually what the nurses want to know, right? They don't care really what the dose is. Because again, they have to do that conversion over from the dose to the volume, and that's kind of hard to do when you're kind of in a high stakes situation. So we'll just list the volume here, that way they know what to administer. Here's an example of what we use for like our RSI drugs. So again, we have atropine and lidocaines, our pre-medications. Here our go-tos were etomidate and succinylcholine. And then actually, if you note here, we also say give atropine prior to succinylcholine, right? Why is that? Because little kids, they're more likely to get bradycardic with succinylcholine, so we'd actually go ahead and pre-treat just for that in that instance there. Now, if I were giving rocuronium instead, would I need to pre-treat with atropine? That's a good question. You do not, right? Because the non-depolarizing neuromuscular blockers do not cause that increase in vagal tone, right? Because again, they don't cause any activation of nicotinic receptors. Because remember, succinylcholine is a depolarizing neuromuscular blocker. Okay, it's an important factor to remember there. And then if we're doing a controlled intubation, maybe like in the ICU, you see they'd use a combination of fentanyl, Versed, maybe propofol. It's a little bit more variable there depending on the situation. And then rocuronium would be their kind of go-to, right? So again, depending on your situation, depending on who you're working with, they may want to have different recommendations for what they use first line. Has anyone ever seen a Broslow tape before? It's the Broslow-Luton tape, and this is actually something developed. If you had a kid who was coding, you did not have an accurate weight, you could actually use this tape here to basically you put one in the head of the child, and then you'd see where their feet land, right, as far as what color it is. So if they landed on blue, they're probably somewhere between 19 and 23 kilograms. Now, what is the inherent downfall of this? If the kid is extremely overweight or underweight, you're going to find you tend to under or overestimate, as the case may be there. So it's better than nothing, but it is one of those things you have to know is pretty fraught, right? So again, if the kid looks to be fairly overweight or underweight, you need to take that into account, maybe either bump them up or down depending on the situation there. But that's typically what you do. Also, it's another problem with getting the height of kids. Yeah, if they're moving around at all, if they're in cardiac arrest, they're probably not moving too much, but maybe if they have like CP or something, they have like contractures or anything like that, it may be difficult having a hard time getting an accurate height on those patients there, right? So again, things to think about. So when you're having a resuscitative experience, hopefully you're not the one having the experience, but you're helping out someone who's having the experience. Things you want to make sure, you always want to call back orders to providers, right, between people, right? So if you're talking to the nurse, if you're talking to the RT, anyone, talking to the doc, you want to make sure you're calling back things and be very specific, right? Give 25 of fentanyl. 25 of what? 25 ducks? You got to be specific, micrograms, okay? And it may sound silly, but this is stuff that you have to practice because, again, when you get in the heat of the moment, it's very easy for things to fall through the cracks. So the more you can do this as a standardized, algorithmic sort of approach, the easier it's going to be and less likely things are going to fall through. Be very precise. You say, I gave an amp of calcium. You say amp, what does that mean? Like what Jimi Hendrix plays on? It stands for ampule, right? It's shortening of ampule. How many ampules do you actually find out there in medicine? Not a whole ton anymore. It's a few. But again, it's kind of an old term nomenclature. But it basically means they gave a whole vial of the medication there. Well, if you say I gave an amp of calcium, well, was that calcium chloride or calcium gluconate? Because that makes a big difference, right? That's either 3 times how much I need or one third of what I need, right? Depending on the situation there. How much is in an amp? You're going to find that an amp of bicarb is 50 mLs. An amp of calcium chloride is 10 mLs, right? So again, you need to be specific with this stuff. You can say I gave 10 mLs of calcium gluconate. Okay, that I know what that means, okay? Always make sure you're using your units, right? So start dopamine at 5. All right, one patient, an actual medication error that actually occurred was said start nitroglycerin at 20. And so the units got screwed up. They meant to say micrograms per hour per minute, and they actually programmed the pumping correctly and used micrograms per kilo per minute. And so the patient got way more than they were supposed to. And they actually ended up draining the whole bag of nitroglycerin. Patients complained of this really pounding headache, as you might imagine, right? Because nitroglycerin does what? It's a vasodilator, right? So again, the patient did okay, didn't get too hypotensive, but it was a big medication error that was could have been caught had we had one standardized pumps that did not have so many different units available, right? So that was one thing we changed. This is an adult facility, and then being very specific and say 5 what, right? 5 micrograms per minute, micrograms per kilo per minute. What do you actually want there? Okay. So any questions on the ACLS meds? Let's do a quick 10-minute break. We'll come back and finish out this section.